Good morning, students. This is Dr. Herndon. I am going to be recording your Chapter 13 lecture here on the recording, and I'm going to upload it to YouTube in just about an hour. Chapter 13 is all about bipolar and related disorders. Bipolar disorder was formerly known as manic depression. Bipolar disorders are chronic, recurrent illnesses that require careful management throughout a person's life. The symptoms include unusual shifts from highs to lows, and this frequently goes unrecognized, and usually people suffer for an average of 6 years before being diagnosed and treated. And here are your objectives for today's lecture, and we'll lecture in class on Tuesday of next week. Describe the symptoms of bipolar 1, bipolar 2, and psychothymic disorder, and then distinguish between mania and hypomania, and then identify the epidemiology of bipolar disorders, and discuss the biological, environmental, and cognitive risk factors for the development of bipolar disorders. And we're going to start off with a case study. You are a registered nurse working in the behavioral health unit of a midtown hospital. As you enter the building near the emergency department, you begin to begin your night shift. You hear a woman at ED intake talking faster than anyone you've ever heard in your life. Her thoughts and speech are racing from one thought to another as she tries to explain something to both the ED nurse and the police officer who assisted her in getting here safely. So, so what are some of the symptoms of bipolar disorder? Or what are the symptoms here that you can identify that would lead you to believe that this particular woman may have a bipolar disorder? Well, symptoms of bipolar disorder include extreme drive and energy, inflated sense of self-importance, drastically reduced sleep requirement, so they don't require a lot of sleep to keep up this energy pace, excessive talking combined with pressured speech, and then personal feelings of racing thought, distraction by environmental events, and unusually obsessed with and overfocus on their goals. Purposelessness, purposeless arousal and movement, and dangerous activities such as indiscriminate spending, reckless sexual encounters, or risky investments. While the DMS-5 describes additional bipolar disorders, in this module, we will focus on bipolar 1, bipolar 2, and psychothymic disorder. With bipolar 1 disorder, this is the most severe bipolar disorder and is marked by shifts in mood, also energy, and the ability to function. And periods of normal functioning alternate with periods of illness, highs, lows, or a combination of both. And many individuals may continue to experience chronic interpersonal or occupational difficulties even during remission. Mortality rate is severe. Suicide accounts for 5% of deaths among women and 10% of deaths among men, compared with 1% and 2% in the general population. Factors related to completed suicide include early onset of the disease, a history of suicide among the first-degree relatives, and previous suicide attempts. Bipolar 1 cases have experienced at least one manic episode, and mania is a period of intense mood disturbance with persistent elevation, expansiveness, irritability, and extreme goal-directed activity or energy. And these periods last at least 1 week for most of the day every day. Symptoms of mania are so severe that this state is psychiatric. The state is a psychiatric emergency. So when they do have the symptoms of mania, It is very severe and it is a psychiatric emergency. Manic episodes usually alternate with depression or a mixed state of anxiety and depression. Initially, people experiencing a manic episode are happy, most excited, and most optimistic. Um, so they're the most optimistic person you can ever meet. And they are euphoric and energized, eating little and sleeping little, and are in perpetual motion. They feel important and powerful and take horrific chances in engaging in hazardous activities. They do not recognize their behavior as problematic. And this, because they think it's normal. They think that their behavior is perfectly normal. Um, this thinking they're normal, even though their behavior is very dangerous, that is called anosognosia and or anosognosia. And as the mania intensifies, the patient may become psychotic, experiencing hallucinations and delusions and dramatically disturbed thoughts. Hallucinations do tend to be auditory, and the person hears voices. And delusions center around self importance and grandeur, such as being famous or being able to end wars. The initial euphoria gives way to agitation and irritability, exhaustion, and then collapsing into depression, leading to extreme behaviors such as violence and attempted suicide. Page 220 speaks of the DSM-5 criteria for bipolar 1 disorders. Let me get that. It's on the second page of this chapter, page 220, at the bottom of the first column of the page, DSM-5 criteria for bipolar 1 disorders. So we need to be familiar with this. And then bipolar 2 disorders is diagnosed as patients who have experienced at least one hypomanic episode and at least one major depressive episode. Hypomania refers to a low level and less dramatic mania and tends to be euphoric and often increases functioning. Like mania, hypomania is accompanied by excessive activity and energy for at least 4 days and involves at least 3 of the behaviors listed under Criterion B in the DSM-5. That's on page 220. And psychotic symptoms may accompany the depressive side of the disorder. And a hypomanic episode impacts functioning that is noticeable to others, is much more talkative and distractible than usual. Hypomania is not usually severe enough to cause serious impairment in occupational or social functioning, and a hospitalization is rare. The depressive symptoms can be profound and may place the patient at risk for suicide. Bipolar 2 disorder is believed to be underdiagnosed and is often mistaken for major depressive disorder or personality disorders when it actually may be the most common form of bipolar disorder. So bipolar 2 disorder is a source of significant morbidity and mortality, especially due to the severe depression. In cyclothymic disorder, symptoms of hypomania alternate with symptoms of mild to moderate depression for at least 2 years in adults and 1 year in children. Hypomanic and depressive symptoms do not meet the criteria for either bipolar 2 or major depressive disorder, but the symptoms are severe enough to cause social and occupational impairment. It may be difficult to distinguish between bipolar 2 disorder. Individuals tend to have irritable hypomanic episodes. Children may experience irritability and sleep disturbances. There is a 15% to 50% risk of progressing to bipolar 1 or bipolar 2. Bipolar 1 or 2 will experience rapid cycling and may have at least 4 mood episodes in a 12-month period. And these mood episodes can be major depressive, manic, or hypomanic. Cycling can also occur within the course of 1 month or even a 24-hour period. Rapid Cycling is associated with more severe symptoms such as poor global functioning, high recurrence risk, and resistance to conventional somatic treatment. Okay, so here's a clinical picture. So with hypomania, we have a low level and less dramatic mania, and it tends to be euphoric and often increases functioning of the individual, and it usually is accompanied by excessive activity and energy. And bipolar 2 disorder must have at least one hypomanic episode to be diagnosed. So this is a question, a practice question for us as we move through. As you wait for the elevator, you hear the officer explaining that the woman was driving erratically. When he pulled her over, he discovered she was not intoxicated, but explained to the police officer that she had not slept in days. So she explained to the police officer that she had not slept in days. As the intake nurse asks questions, the woman keeps starting to answer, but then looks all around her, distracted by other patients, people in the waiting area, etc. And you hear her say, "Okay, okay, look, I'm bipolar." So your elevator arrives. So symptoms of the manic state include extreme drive and energy, inflated sense of self-importance, a drastically reduced sleep requirement, excessive talking combined with pressured speech, personal feelings of racing thoughts. They are distracted by environmental events and usually obsessed with and over focus on goals, and they have purposeless arousal and movement, and they partake in dangerous activities such as indiscriminate spending, reckless sexual encounters, or risky investments. Some other bipolar disorders, several other bipolar and related disorders are included in the DSM-5. We have substance medication-induced bipolar and related disorder, and this is directly related to substances and further specified by whether the onset occurred with intoxication or with withdrawal. The symptoms include elevated, expansive, or irritable mood or depressed mood, which causes clinically significant distress and then impacts functioning of the person. The bipolar and related disorder due to another medical condition. This may include mania or hypomania that may be mixed with depression that is directly related to a specific condition, and it can be verified through history, physical examination, or laboratory finding. The symptoms include elevated, expansive, or irritable mood or depressed mood. And the depressed mood, all of these mood swings cause clinically significant distress, and it impacts their functioning. So we're going to go through some more parts of this case study. Just as you arrive on your unit, you learn that a new patient is soon to arrive. You learn that it's the woman you saw downstairs. Based on what you have seen of this patient already and what she has said, what symptoms might you expect to see when she arrives? So your 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 distractors include A, catatonia, B, expression of racing thoughts, C, low self-esteem and tearfulness, or D, lack of interest in her environment. Well, your correct answer is going to be B, expression of racing thoughts. So the symptoms of the manic state include extreme drive and energy, inflated sense of self-importance, drastically reduced sleep requirement, excessive talking combined with pressured speech, personal feeling of racing thoughts, distraction by environmental events, unusually obsessed with and over-focused on goals, and purposeless arousal and movement, and again, dangerous activities such as indiscriminate spending, reckless sexual encounters, or risky investments. So this is this is the same symptoms that we've talked about in the last 2 or 3 slides. Men and women have nearly equal rates of bipolar disorders, yet they respond somewhat differently to their condition. Men with a bipolar disorder are more likely to have legal problems and commit acts of violence. And then women with a bipolar disorder are more likely to misuse alcohol, commit suicide, and develop thyroid disease. Table 13.1 provides a snapshot of statistics regarding bipolar disorders in adults and adolescents ages 13 through 18. Men with a bipolar disorder are more likely to have legal problems and commit acts of violence. We've said that already. Women with a bipolar disorder, again, they're more likely to misuse alcohol and substances, and they do commit suicide more often and develop the thyroid disease more often. Women who experience a severe postpartum psychosis within 2 weeks of giving birth has a 4 times greater chance of subsequent conversion to bipolar disorder. Giving birth may act as a trigger for the first symptoms of bipolar disorder. The precipitant may be hormonal changes and sleep deprivation for this bipolar disorder to come on and to be diagnosed. So sleep loss after childbirth may trigger mania and psychosis in women with pre-existing bipolar disorder. So really the disorder has been there. It's not been triggered to for the actual severe symptoms of these individuals, but sometimes when they have a lot of lack of sleep, and the stress that comes with childbirth, it may trigger this mania and psychosis in these women, and then they are diagnosed with bipolar disorder. Children, early on, children were diagnosed with bipolar disorder, but due to problems with the stigma of the diagnosis and the fact that strong medications were used, as well as children not having bipolar symptoms as adults, the diagnosis was changed in children, and what we call that in childhood is disruptive mood dysregulation disorder. So bipolar disorder in late adolescence mirrors that of the adult. Early onset is associated with high rates of suicide attempts. Girls make more attempts than boys, and these adolescents experience role, familial, and social and academic impairment. So on your screen, we have the epidemiology listed as lifetime risk for overall is nearly 4%, men and women, nearly equal rates, and then severe postpartum psychosis is 4 times has 4 times greater the risk if that's a factor, and then children and adolescents disruptive mood dysregulation disorder is what we call these symptoms in children, and we don't give them the harsh medications that we would give an adult with these symptoms. The cyclothymic disorder, adolescents and early adulthood, people are more diagnosed with cyclothymic disorder in adolescence and early adulthood, and there's a 50% risk of subsequent bipolar 1 or 2 with that disorder. Okay, regarding substance use disorder, researchers have questioned if the substance use in patients is an attempt to self-medicate. More than 50% of individuals have an alcohol use disorder, which is a problem associated with increased risk for suicide. Alcohol is a depressant. Further complications include a higher than normal rate of serious medical conditions. Migraines are more common. Metabolic syndrome is common. Metabolic syndrome, if you don't know what that is, it is a cluster of problems such as high blood pressure, high blood glucose, and excessive body fat around the waist. And abnormal cholesterol levels may lead to premature death due to heart disease, stroke, and diabetes. So, nearly all anxiety disorders are associated with bipolar 1, affecting about 75% with this disorder. Panic attacks, social anxiety disorder, and phobias are part of this. And then other disorders may complicate the clinical presentation and the management of bipolar, attention deficit and hyperactivity disorder, and then all disruptive impulse control or conduct disorders. Substance use disorder present in over half of those with bipolar 1, as we said, and then serious medical conditions also will be present in a lot of these patients. As with bipolar 1, about 75% of individuals with bipolar 2 disorder have comorbid anxiety disorders. Most of the time, the anxiety disorder comes about before the hypomania and depressive symptoms. Eating disorders, especially binge eating disorder, affects around 14% of the population, of this population. And substance use disorders are also common and affect about 37% of people with bipolar 1. Anxiety and eating disorders seem to be associated with the depressive side of bipolar 2, and substance use disorder symptoms arise along with hypomanic symptoms. Anxiety and eating disorders seem to be associated with the depressive side of bipolar 2, and while substance use disorder symptoms arise along with hypomanic symptoms, so this is interesting, the association with the eating disorders. But again, 75% of individuals with bipolar 2 have comorbid anxiety disorders, and then eating disorders, particularly binge eating disorder, affects about 14% of those with bipolar 2. And then you have your substance use disorders. Okay, substance use disorders are common with cyclothymic disorder, and this may be due to efforts to self-medicate and subdue the symptoms. Sleep disorders where people have difficulty going to sleep and staying asleep are often present in this disorder. Attention deficit hyperactivity disorder is more common among children with psychothymic disorders than with the other mental health conditions. And so those are 3 of the areas of concern. So this is a case study. An assessment interview revealed that your new patient from downstairs, Mrs. A, she is 53, is an adjunct college English teacher who claims to also be a novelist. Bipolar was almost inevitable, she says. I grew up in a family of 5 girls with competitive, ego-driven parents. It was hellish. As soon as I got a scholarship, I ran as fast as I could to college, where I absolutely lived on coffee, books, and the drama department. I lost my job, but I'm a novelist now. Okay, so here are the risk factors for bipolar. The lifetime prevalence for bipolar disorder is 3.9%. However, for individuals with affected family members, the risk is far greater. The concordance rate among identical twins is estimated to be around 60%. So if one twin has bipolar, then the other twin has a 60% chance of having it or developing it. Genetics, some evidence suggests that bipolar disorders are more prevalent in adults who had high intelligence scores or IQs, high IQs, and particularly verbally high in the verbal area as children. People with bipolar disorders appear to achieve higher levels of education and higher occupational status than individuals with unipolar depression. The proportion of patients with bipolar disorders among creative writers, artists, highly educated men and women, and professionals is higher than in the general population. Genetic relationships between psychiatric disorders are being discovered with 30 loci that were genome significant, containing genes for encoding ion channels neurotransmitter transporters and synaptic components. Based on genetic similarity, conclusions of the study include that bipolar 1 is strongly genetically correlated with schizophrenia with psychotic features, while bipolar 2 is more strongly correlated with major depressive disorder. Another study has discovered overlap between bipolar disorder, schizophrenia, and autism. In regard to neurobiological issues, the neurotransmitters such as norepinephrine, dopamine, and serotonin were the early focus in research of mania and depression. A simple explanation is that too few of these chemical messengers will result in depression, and an overabundance will bring about mania. However, proportions of neurotransmitters in relation to one another may be more important. Receptor site insensitivity could also be a piece of the puzzle. So in other words, even if there are enough of a certain type of neurotransmitter, in this case, it is not getting to where it needs to go. So with bipolar disorder, functional imaging techniques reveal dysfunction in the prefrontal cortical region, and that is the region associated with executive decision making and personality expression and social behavior. Dysfunction is evident in the hippocampus, which is primarily associated with memory, and the amygdala, which is associated with memory, decision making, and emotion. Dysregulation in these areas result in the characteristic emotional lability, heightened reward sensitivity, and emotional dysregulation of bipolar disorder. And these abnormalities may be due to gray matter loss in these areas. The neuroendocrine piece to this is that the hypothalamic pituitary thyroid adrenal axis, that is called the HPTA axis, has been researched in bipolar disorder. Hypothyroidism is one of the most common physical abnormalities associated with bipolar disorder. Because the thyroid dysfunction is not dramatic, the problem is sometimes undetected. Peripheral inflammation in both manic and depressive states. Peripheral inflammation is increased and tends to decrease in between episodes, and these findings are consistent with the HPTA axis, which are known to drive inflammatory activation. Systemic inflammation is associated with a broad cognitive dysfunction in people with bipolar disorder. Environmental factors, children who have genetic and biological risk of developing bipolar disorder are very vulnerable in bad environments, such as stressful family life and adverse life events resulting in severe course of illness. Stress is also a trigger for mania and depression in adults, and childhood adversity in forms of physical, sexual, and emotional abuse and emotional neglect are significantly associated with bipolar disorder. Emotional abuse has the largest association and is 4 times more likely to have occurred in bipolar patients than in controls during research studies. Childhood mistreatment is also associated with poor clinical outcomes, with more frequent and severe episodes, earlier onset, risk of suicide, and substance misuse. And the cognitive factors include that mania was once thought to be a defense mechanism underlying anxiety and depression, and was thought to help individuals tolerate loss of tragedy such as death of a loved one. The psychodynamic theorists believe that a faulty ego uses mania when it is overwhelmed by pleasurable impulses such as sex or feared impulses such as aggression. An overactive and critical superego is replaced with the euphoria of mania and has also been suggested as the cause. With improved neuroimaging techniques and treatment advances, psychological theories have largely been dismissed. Bipolar 1 genetic similarity to schizophrenia is found. Bipolar 2, it is strongly correlated with major depressive disorder. And in research, the finding is that they have found a significance in the neurotransmitter imbalances in the brain, in the brain structure and the brain function, and also the changes in the HPTA axis. They have looked at hypothyroidism in this, as we said earlier. For environmental, there are links to childhood trauma or stress. And in regard to cognitive factors, with the advent of improved neuroimaging techniques and treatment advances, psychological theories are largely dismissed. So that psychological theories that they proposed early on are dismissed with the improved neuroimaging techniques that we use now. So based on her history, which factors can you identify that may have an influence on Mrs. A's condition? Is it biological factors? Is it cognitive factors? Or environmental factors? Or all of the above? So the answer is D, all of the above. Mrs. A's nuclear family life shows sign of biological factors that had put her at risk. This was compounded by the more intense psychological and environmental factors of growing up in a dysfunctional household. And here are your objectives for the presentation moving forward. Formulate 3 nursing diagnoses that support care for a patient with mania. Describe the difference in care for the acute phase versus the maintenance phase of mania and hypomania, and evaluate specific indications for the use of seclusion by patient experiencing mania. And individuals with bipolar disorder are often misdiagnosed or underdiagnosed. Early diagnosis and proper treatment can help people avoid suicide attempt, alcohol or substance use problems and disorders, marital or work problems, and development of medical comorbidity. Figure 13.2 presents the Altman self-rating mania scale, which is useful in capturing a picture of the patient's placement on the depression to mania continuum. Scores of 6 or higher suggest mania or hypomania and the need for further assessment and/or treatment. People with bipolar disorder tend to spend more time in a depressed state than in a manic state. For the next slide, we will focus on the mania characteristics. Mood, we'll look at the euphoric mood association with mania, and it is unstable, and patients may experience intense feelings of well-being, as being cheerful in a beautiful world or as becoming one with God. And the overly joyous mood may seem out of proportion to what is going on in the present time, and cheerfulness may be inappropriate for the circumstances, especially when patients are full of energy with little or no sleep. Examples of behavior include laughing, joking, talking in a continuous stream, demonstrating extreme enthusiasm, and becoming confidently friendly, and incorporate everyone into plans and activities, meeting no strangers and having endless energy and abundant self-confidence. And the euphoric mood associated with mania is unstable because it may change quickly to irritation and anger. During the manic state, the client is busy all hours of the day and night, furthering grandiose plans and wild schemes. For the person with mania, no aspirations are too high and no distances are too far. The person experiencing mania may be manipulative, profane, fault-finding, and skilled at detecting vulnerabilities and then exploiting them. And these people constantly push their limits. They push the limits with which alienates them from others, and dress and makeup is inappropriate. Splitting is a tendency. Remember, we defined splitting last in the early part of this course, the last couple of lectures. But this is the definition of this is thinking that people are either all bad or all good. So that's what splitting means. And then these are just some of the assessment findings that you will have when assessing your patient. Mrs. A further describes her childhood, a part of her life she finds particularly troubling. We all had to compete if we wanted attention. Dad played favorites depending on our grades and talents. I was his favorite, but I hated to be. Excuse me. I hated it because it made my mother hate me. How could the how could I compete with her? How could she compete with her own daughter? And sometimes in high school, I scared myself with how much I just wanted to hurt them both. Sometimes I still do. And I'm writing a novel about my life. It is it's won a lot of awards and it's not even finished. I wrote to a famous actress about playing my role. Excuse me. I'm pretty sure she'd find um, my life highly interesting. A role at a role of a freaking lifetime is what she says. So this is her words. Mania causes people to experience disorganized thoughts and speech patterns, leading to pressured speech and circumstantial speech and tangential speech. They lose associations during conversation and they have flight of ideas, and they use clang associations, which are rhyming without regard to the meaning. So they just want to rhyme the words. And the person may have grandiose delusions that are manifested by high inflated self-regard or persecutory delusions and think God is punishing them or that the FBI is spying on them. And they may result to violence for the imagined persecutions. And the person's onset of bipolar disorder is preceded by comparatively high cognitive function, and with the mania, the people have milder but similar cognitive deficits as people with schizophrenia. So, so on your slide, you see that you're continuing this assessment, and the thought processes and speech patterns do include the pressured speech, the circumstantial speech, the tangential speech, the loose associations, the flight of ideas, the clang associations, and that's a rhyming words that don't have anything to do with a similar meaning. And then the thought content would be the grandiose delusions and the persecutory delusions. And further assessment, furthering this assessment piece is the cognitive dysfunction that will have clinical implications, and it affects the overall function of a person. And then the cognitive deficits correlate with manic episode, the history of psychosis, chronically chronicity of illnesses, and the poor functional outcome. Early diagnosis and treatment are crucial to prevent illness progression and cognitive deficits and the poor outcome. And then your medication selection should consider not only the efficacy of the drug in reducing mood symptoms, but also the cognitive impact of the drug on the patient. But you will not be selecting the drugs. Your primary care provider, your physician will be selecting the drugs, but you as a nurse will need to know, and you should know, um, how these drugs are functioning with the patient and how the physician selects the drugs. And again, you may become, that nurse practitioner who is specializing in mental health. So it's a great thing to get ahead of knowing all of these medications um, and making an effort to look at the medications and the selection of medications that are considered and uh, that are prescribed regarding the efficacy of the drug in reducing the mood symptoms, but also the cognitive impact of the drug on your patient. So all of this is important for you as well as the physician. So Mrs. A keeps mentioning she's writing a prize-winning novel about her life and is pretty sure a famous actor will want to play the role of herself. What type of symptom is she displaying? Is it flight of ideas? Is it tangential speech? Is it loose associations? Or is this grandiose delusion? So this one would be grandiose delusion. Answer D. Grandiose delusions are manifested by a highly inflated self-regard. It is apparent in both the ideas expressed and the person's behavior here. So people with mania may exaggerate their achievements or importance or state that they know famous people. And this patient makes some unlikely and uncomfortably boastful claims that her novel about her life has already won a number of big prizes and that a particular famous actor will want to play the role of herself. And this is all um, also, that it has not been published yet. So this is all pretty incredible findings based on the fact that it has not been published yet. So this is a case study discussion. What are some problems that can be avoided if Mrs. A gets proper treatment? Well, we'll talk about this in class, but some of the problems, some of the early diagnosis and proper treatment that can help people avoid suicide attempts, alcohol or substance use problems and disorders. Marital or work problems can be avoided if she is treated, and the development of medical comorbidity can be avoided if she is treated. And if you are witnessing someone experiencing mania, it is very likely that you will feel uncomfortable, and this discomfort may be brought on in part by the patient's decreased personal space and intrusive comments, and you may feel afraid, inadequate, or angry, or all of the above. Understanding, acknowledging, and sharing your responses will enhance your professional ability to care for the patient. So it's important that you collaborate with other staff members. Your faculty member will be on hand if you're in a clinical situation and you start to feel these feelings. And sharing your experience with your peers during post-conference may be helpful as well. So um, I don't know how close you're working with some of these patients, but if you do start to feel any of these feelings, you do need to talk about them. And then as you move forward to become a nurse, it's also important that you protect your self from burnout and that you have a mentor and that you are able to talk about certain cases so that you can work these details out in your heart and in your mind so that you're not experiencing burnout. Okay, so these are the assessment guidelines for bipolar disorder. Um, these individuals are a danger to self or others, or you need to assess whether or not they're a danger to self or others. You need to assess for the need of protection from uninhibited behaviors and assess whether there is a need for hospitalization. Um, what is the medical status of this person experiencing these disorders? And is there a coexisting medical condition that's underlying? And then also assessing the family's understanding of the diagnosis or of the problem. And you need to pay attention to the assessment guideline box for bipolar disorder on page 226. So that would be very important for you as far as test purposes go, and also just to be a good have good critical thinking skills and be a good nurse to your patients. And these are some of the nursing diagnoses that you could come up with for your patients with bipolar disorder. There is a risk for injury, a risk for violence, sleep deprivation, impaired cognition, impaired concentration, self-care deficit, in regard to feeding, bathing, and dressing, and there may be others, and also impaired socialization. Table 13.2 is important to study in regard to nursing diagnoses, but nursing diagnoses will vary. A primary consideration for a patient in acute mania is the prevention of exhaustion. Because of the patient's poor judgment, excessive and constant motor activity, probable dehydration, and difficulty evaluating reality, there is a risk for injury, or there will be, or it is likely that there will be, and it is likely that that's an appropriate nursing diagnosis for your patient. And then the outcome criteria will be based upon which of the three phases of the illness that the patient is experiencing. The three phases are acute, continuation, and maintenance. And the acute phase begins with the onset of a new manic and hypomanic episode, and the goals are symptom reduction and achieving remission from the episode. Nursing care centers around supporting these goals while supporting injury prevention and physiological integrity. And the goals on the screen are important as well as to be uh, well hydrated. So that is a important outcome because these people are on the go. They're talking nonstop. They're active, and so they probably don't have time for hydration. So we need to make sure that they're hydrated. So on your screen, you see the acute phase. You see prevent injury, maintain stable cardiac status, and maintain hydration, tissue integrity, and get sufficient sleep and rest, and demonstrate self control, and then attempt no self-harm. Okay, so the team meets with Mrs. A to identify outcomes and develop a care plan for her. She asks why safety is such a big concern. Why indeed? So, is why is the safety such a big concern? Is it A, she's at risk for exhaustion? B, she's at risk for dehydration? C, she's having difficulty perceiving reality? Or D, all of the above? So it is, of course, D, all of the above. All three of these are distinct aspects of the diagnosis risk for injury for someone in an acute bipolar state. Like many other patients experiencing an acute state, she is at risk for exhaustion because she has not been able to eat or sleep for days, and this creates poor impulse control out of sheer exhaustion, and led to her being pulled over for driving erratically, as well as putting her body at significant risk as well. So extended exhaustion and dehydration can cause systems damage, excuse me. So her difficulty perceiving reality contributed heavily to her dangerous driving, and also means she cannot be left alone or in control and should be hospitalized because she is a danger to herself. Okay, so the maintenance phase here, during this stage, the most acute symptoms have been controlled. The longer term maintenance phase begins after the resolution of an acute episode, and the goal is now on preventing future exacerbations of the mania or hypomania. So, in the maintenance phase, we need to obtain knowledge of the disorder, management, and medication. And this would include identifying 3 risk factors for the development of acute mania, identify preventive strategies, and then identify sources of support. And this may be in the form of attending group therapy on a daily basis. And then her problem solving skills, identify new coping skills. She's going to have to look at new coping skills because she clearly is not using good coping skills up to this point. So she's got to kind of think about that, think about how she can keep herself safe. Planning in the acute phase. During an acute manic phase, planning focuses on medically stabilizing the patient while maintaining safety, and the hospital is usually the safest environment for accomplishing this stabilization. Nursing care is geared toward managing medications, decreasing physical activity, increasing food and fluid intake, and also ensuring 4 to 6 hours of sleep per night and intervening so that self-care needs are met. Seclusion, restraint, or electroconvulsive therapy may be considered during the acute phase. If because some of the medications won't be able to be in her body and given time to work because most of them take at least 3 weeks. So if she is out of control during that time, the physicians may consider the ECT to be something that would help her. So during the maintenance phase, planning focuses on preventing relapse and limiting the severity and duration of future episodes. Patients will require medications over long periods of time for their lifetime. And so during this time, patients face interpersonal, familial, occupational, educational, and financial hardships that resulted from the acute phase of the illness. Residual problem that resulted from reckless, violent, or bizarre behavior leaves lives shattered and family and friends hurt and distant. Patients will need support as they do not only recover from the acute illness, but also need to address repairing their lives. So on your screen, you have preventing the relapse, limiting severity and duration of future episodes, and looking at the medications and considering long-term, long periods of time over the entire lifetime for the medication. And then we look at supporting patients in repairing their lives from the hardships that come out of the acute phase of this illness. And patients with bipolar disorder are often ambivalent about the treatment. On average, people wait almost 10 years between the onset of symptoms and receiving treatment. Self-medicating through alcohol or substances complicates the clinical picture and contributes to treatment delay. Patients may minimize the destructive consequences of their behaviors or deny the seriousness of the disease, and some are reluctant to give up the increased energy, the euphoria, and heightened sense of self-esteem of hypomania. Unfortunately, the lack of adherence to mood-stabilizing medication is a major cause of relapse. For the nurse, establishing a therapeutic alliance with the patient with bipolar disease is crucial to support continued treatment. The nurse can use therapeutic communication to um, kind of help guide the patient in making best choices for them, and to explain the reason that the medications are good and are necessary for them to prevent relapses. Um, Depressive episodes of bipolar disorder have the same symptoms and risk as major depressive disorder. although they are more intense, and hospitalization may be required if there are suicidal ideations, if there is psychosis or catatonia is present. And that's when the catatonia, again, that's when they can't move. They don't their eyelids don't blink. Um, they just are just very still. They're nonverbal, and pharmacological treatment is impacted by concerns of bringing on a manic phase. For the manic episodes, hospitalization provides safety for a person experiencing acute mania and bipolar 1 disorder. It imposes external control on the destructive behaviors and provides medication to stabilize the patient. And staff members are on hand to continually set limits in a firm, non-threatening, and neutral manner to prevent escalation of behavior and provide safe boundaries for them. We have a table 13.3. It provides interventions for patients who are experiencing acute mania, and it would be in your best interest to look over that table and to know that table. And so we'll discuss this in class, and we'll talk about the page numbers and that kind of thing. The maintenance phase, during the maintenance phase, the interventions are geared toward the prevention of relapse, with medication adherence being essential and adequate, and regular hours of sleep are important. The healthy nutrition and community support also is essentially maintained for the patient in order to prevent the relapse from happening. Individuals at this stage will likely be engaged with community resources and using outpatient facilities such as mental health centers, outpatient clinics, and psychiatric home care. Outpatient services provide medication management and structure for a decrease in social isolation and a channel for time and energy. The implementation for acute mania, and this includes hospitalization. This slide just goes over pretty much what we just said. It provides safety for a person experiencing acute mania and imposes external controls on destructive behaviors, and then provides medication for stabilization. So those are the three goals, and we want to maintain all three. And then this is your communication technique. There are unique approaches to communicating with and maintaining the safety of the patient during the hospitalization period. This is table 13.3. And staff members continuously set limits in a firm, a non-threatening, and a neutral manner in order to prevent further escalation of mania and provide safe boundaries for the patient and others. So this just kind of, this is the 3-step that we just spoke of. We use firm and calm approaches. We use short, concise explanations for the patient, and we identify the expectations in simple, concrete forms. And there are unique approaches to communicating with and maintaining the safety of the patient during the hospitalization period. This again is included in table 13.3. Staff members continuously set those limits in a firm, non-threatening, and neutral manner to prevent further escalation of mania and to provide safe boundaries for patient and others. So we hear and act on legitimate complaints. We firmly redirect energy into more appropriate channels for the patient. And although she is not aggressive, the treatment team finds Mrs. A bit hard to handle. She seems to have forgotten personal boundaries and is argumentative about every little issue, every little rule. And she asks one nurse if she can please stay out in the TV room after lights out to watch a movie that starts at midnight that she just has to see. When that nurse says no, she approaches the second nurse and says that the first nurse said it was okay with him. She is delivered to her room, and the team has a meeting to improve the communication plan. And so during the implementation maintenance phase, we must focus on preventing relapse. We focus on medication adherence. This is essential. We have a regular and adequate sleep rule for the patients to so that they will not be fatigued. And we have healthy nutrition for them to support their health. We have community support and engagement with the community resources. And then we use the use of outpatient facilities is there for those who are not hospitalized. And patients and families need information about bipolar illness with an emphasis on the chronic and highly recurrent nature. Patients and families also need to learn the warning signs and symptoms of the impending episode, such as changes in sleep patterns. This is especially important because these usually precede or accompany or precipitate mania. Even a single night of unexplainable sleep loss can be taken as an early warning of impending mania. Health teaching stresses the importance of establishing regularity in sleep patterns and meals and exercise and other activities. And Box 13.1 lists health teaching guidelines for patients with bipolar disorders and their families. Most medications used to treat bipolar disorders may cause weight gain and other metabolic disturbances such as altered metabolism of lipids and glucose, which increase the risk of diabetes, high blood pressure, dyslipidemia, cardiac problems, or all of these in combination. And all of these in combination is usually called the metabolic syndrome. These side effects are a major reason for patient non-adherence. And the best method of addressing the problem of medication adherence is to use a collaborative care model where responsibilities for treatment adherence is shared. Patients are responsible for making it to appointments and openly communicating information, and the healthcare provider is responsible for keeping current on treatment methods and listening carefully to the patient as they share their perceptions of the plans. And Box 13.1 lists health teaching guidelines for patients with bipolar disorder. So on your screen here, excuse me, on your screen, we have information about bipolar illness, understanding its recurrent nature, and warning signs of impending episodes are important to teach to patients and their families. Again, the importance of regularity, the sleep patterns, the meals, the exercise, other activities in their life, and group and individual therapy. Patients with bipolar disorder, as well as their friends and families, do benefit from support groups such as those sponsored by the Depression and Bipolar Support Alliance, that's DBSA, and the National Alliance for the Mentally Ill, that's NAMI, and the National Mental Health Association and the Manic Depressive Association. So there are associations that can help support patients with groups, group therapy, or group support groups. And interprofessional staff work together to create a climate of teamwork and safety. And this is essential for patients who are at risk of self-harm during a depressive phase or at risk for self-harm or other harm during the acute phase. Frequent team meetings to plan strategies for dealing with challenging patient behaviors are very important. They're essential. And these meetings help to minimize staff splitting and may reduce feelings of anger, fear, and isolation. And limit setting, such as lights out after 11 o'clock p.m., is the main theme in treating a person in a manic state. So we have to set the limits and stick to it, and we have to come together to agree to do that as a team on a unit. So we have to have those frequent staff meetings to deal with patient behavior and staff response, and set limits constantly, consistently as a team. Control of hyperactivity during the acute phase almost always includes immediate treatment with an antipsychotic drug, and when a patient is dangerously out of control, the use of seclusion room or restraints may be necessary. The use of seclusion or restraint is associated with a complex therapeutic, ethical, and legal issue, and most state laws prohibit the use of unnecessary physical restraint or isolation. So unless it's an emergency, the use of seclusion or restraints requires the patient's consent. Seclusion and restraint may be warranted when documented data collected by the nursing and medical staff reflect the following. Substantial risk of harm to others or self is clear. The patient is unable to control their actions or other measures have failed. So in those instances, we must have a physician's order for the restraint or the seclusion, and this must be reviewed and rewritten every 24 hours. And it must include what type of restraint is used. Only in an emergency can a charge nurse place a patient in a restraint. A written order must be obtained within a specified time period, such as 15 to 30 minutes, and protocols are in place guiding specific nursing responsibilities, such as how often to observe the patient, document the patient's behavior, how often to offer food and fluids, and that is usually every 30 to 60 minutes, and how often the patient can use the restroom, and that is usually every 1 to 2 hours. And caregivers should measure the vital signs frequently every 1 to 2 hours. Communication with the patient in seclusion is concrete, direct, and empathetic, and reassuring. That seclusion is only a temporary measure and that they will be returned to the unit when they demonstrate the ability to safely and be around others. So that they are reassured to that constantly. Restraints are never used for punishment or for the convenience of staff. And really, seclusion and restraints are not convenient to the staff because they require so many other tasks that the staff have to perform what that has been written as an order. These were placed in a virtual venue during the COVID pandemic and likely would not go back face to face due to increased growth in teleconferencing and improved attendance. Um, these are support group sources, Depression and Bipolar Support Alliance, the National Alliance on Mental Illness and Mental Health America. So during COVID, these became virtual instead of face to face, and so now they've just gotten used to the virtual venue, and they're probably never going to go back to face. And these are just your evaluation pieces. We need to evaluate the outcome criteria and reassess the outcome and care plan, revise care plan if indicated. And for long-term outcomes to be added in time, we need adherence to the medication regimen. We need resumption of functioning in the community, the achievement of stability in the family, the work, the relationship, and the mood, and then improved coping skills for reducing stress. And these are your objectives for the rest of the presentation here: to identify medications used for mood stabilization, including lithium, anticonvulsant drugs, and second-generation antipsychotics. Also, distinguish between signs of early and severe lithium toxicity, and then identify 5 areas of patient and family teaching regarding lithium carbonate. So this is very important. Individuals with bipolar disorder may be on multiple medications. For severe agitation, lithium or divalproex and a second-generation antipsychotic such as olanzapine or risperidone are recommended. So if patients are having less severe symptoms, one of these may be prescribed. And there may be times when a benzodiazepine and anti-anxiety agent can help to reduce agitation or anxiety. Due to the concern of dependency, the use of benzodiazepines is usually short-term until the mania subsides. The high-potency anti-anxiety benzodiazepine, clon, clonazepam, or Klonopin, and Ativan are useful in the treatment of acute mania. They may calm agitation and reduce insomnia. Also, they may reduce aggression and panic. And so the mood stabilizers refer to a class of drugs used to treat symptoms associated with bipolar disorder. And all of these drugs can be used in mania, but only some are used in the depressive states. Lithium carbonate is approved for acute mania and maintenance treatment of bipolar disorder. Onset of action is within 10 to 21 days. Because the onset of action is slow, a second-generation antipsychotic or anticonvulsant or anti-anxiety medications are usually given at the beginning of treatment, and the clinical benefit of lithium can be very good, but newer drugs carry lower toxicity and have more favorable side effects and require less frequent laboratory testing. So the use of lithium has decreased because of all of that. Page 232 has a list of lithium uses, and it looks at decreasing symptoms of bipolar disorder. On page 232, your text lists symptoms that lithium can work to decrease. These include elation, grandiosity and expansiveness, flight of ideas, irritability, manipulation, anxiety, self-injurious behavior. So to the lesser extent, lithium controls the following: insomnia, psychomotor agitation, threatening or assaultive behavior, distractibility, hypersexuality, and paranoia. So discuss table 13.4 here, which details expected side effects of lithium, such as lithium toxicity and interventions for that. So lithium has a small therapeutic window and must reach therapeutic load levels to be effective, and that usually takes 7 to 14 days or longer in some patients. In the acute manic state, it is usually started at 600 to 1200 milligrams per day in 2 or 3 divided doses. It is then increased every few days by 300 milligrams per day with a maximum dose of 1800 milligrams a day. The target range for a 12-hour serum trough level is 0.8 to 1.2 milliequivalents per liter, and a greater clinical benefit for acute mania may be found in a level of 1.0 to 1.2 milliequivalents per liter. During the maintenance phase, lithium can be cut back to doses ranging from 900 to 1200 milligrams a day, and the target serum lithium level for maintenance is 0.6 to 0.8 milliequivalents per liter. This may be important for you to know and to consider and to remember, because and I'll say that again, the target serum lithium level for maintenance is 0.6 to 0.8 milliequivalents per liter. Levels of 0.4 to 0.6 milliequivalents per liter may be considered as adjunctive treatment for bipolar 1 patients or monotherapy for bipolar 2. In table 13.4 details the expected side effects of lithium, signs of toxicity, and interventions. So that table is important. And the first lithium level should be drawn every 2 to 3 days after beginning lithium therapy and after any dosage change until the therapeutic level is reached. Blood levels are then checked every 3 to 6 months thereafter, and for older patients, start low and go slow. So, before administering lithium, the baseline assessment for renal function and thyroid status, and other clinical and laboratory assessments, including electrocardiogram, all of those are needed. I need you to look at box 13.2 on page 234. It outlines patient and family teaching for lithium therapy. That is very important. And contraindications to lithium is in patients with cardiovascular disease, brain damage, renal disease, thyroid disease, or myasthenia gravis. So that's a thyroid disorder, and you need to know what that is. Lithium is not given to pregnant women whenever possible because it may harm the fetus. And lithium is also contraindicated in breastfeeding and in children younger than 12. So there's a lot about lithium that you need to read and know. Okay, Mrs. A started on lithium. Discuss what patient teaching about this medication the nurse should provide before the patient is discharged. The patient and family should be given careful instructions about, number one, purpose and requirements of lithium therapy. Number two, its adverse effects. Number three, its toxic effects and complications. Number four, situations in which the physician should be contacted. And number five, the need for periodic blood tests to monitor lithium levels. Patients also need to know that two major long-term risks of lithium therapy are hypothyroidism and impairment of the kidneys' ability to concentrate urine. So those two things are extremely important for you to know. The anticonvulsant drugs or anti-epileptics were developed to treat seizures associated with epilepsy, and the FDA approves these for use in acute mania, acute bipolar depression, and or bipolar maintenance, and they are generally superior for continuous cycling patients and more effective when there is no family history of bipolar disease. They are also effective in diminishing impulsive and aggressive behavior in some non-psychotic patients and helpful in cases of alcohol and benzodiazepine withdrawal and beneficial in controlling mania within 2 weeks and depression within 3 weeks or longer. Valproate, that is available as Depakote and valproic acid. The FDA has approved this treatment for acute mania and helping in preventing future manic episodes. The side effects include nausea, weakness, somnolence, indigestion, diarrhea, dizziness, and vomiting. And we have to monitor the liver function when patients are on this drug. Low platelets or thrombocytopenia may occur here with these patients. Pancreatitis has been reported in patients taking Depakote and valproic acid. The FDA has a black box warning against valproate use in pregnancy due to teratogenicity. So there could be some birth defects in patients, in the fetuses of patients using this. And so that word, again, let me repronounce that word. I apologize. So it's teratogenicity, and patients should be screened for pregnancy and use of birth control before you prescribe this drug, or before the physician prescribes it and before the patient takes it. The carbamazepine is indicated for acute mania and mixed states and considered a second-line therapy due to complex drug interactions and adverse effects. A common side effect would include dizziness, somnolence, nausea, vomiting, tachia. Excuse me, I had to get a little sip of water. Also, constipation, pruritus, dry mouth, weakness, blurred vision, and speech problems. Liver enzymes must be monitored for the first 8 weeks. If out of normal values, it can cause bone marrow suppression and liver inflammation. So we have to monitor those liver enzymes. It does carry a black box warning for serious dermatologic reactions, including toxic epidermal necrolysis. and Stevens-Johnson syndrome, and this happens in 1% of people using this drug. Asian ancestry has 10 times a greater risk for the Stevens-Johnson syndrome. Lamotrigine is an FDA-approved maintenance therapy medication approved for those 18 years and older. The common adverse reactions are dizziness, headache, diplopia or double vision, ataxia, blurred vision, nausea, somnolence, rhinitis, and pharyngitis. In 10% of people, a rash appears within 8 weeks of treatment, and if this occurs, this drug is discontinued. And the second generation antipsychotics, a list of drugs is on your screen here. Specific medications are indicated for bipolar depression, the second generation antipsychotics, Latuda, Seroquel, and Verelar have FDA approval for treatment of bipolar depression. Symbiox is another drug with approval for this type of depression. It is made up of the second generation antipsychotic, olanzapine or Zyprexa, and the selected serotonin reuptake inhibitor antidepressant fluoxetine or Prozac. And these are some of your integrative therapies. We have omega-3 fatty acids. These come in the form of cod liver oil or fish oil, and there is no evidence to support use in treating mania with this therapy. There is strong evidence that they may improve depression symptoms. And these are the objectives for the next few slides. Discuss the role of brain stimulation therapy such as electroconvulsive therapy and repetitive transcranial magnetic stimulation in treating bipolar disorders, and then identify psychological therapies that are used in treating the patient and family with bipolar disorders. And so for electroconvulsive therapy, one major advantage of the ECT is that it works more quickly than medication in improving the depressive symptoms. It usually works within a week. And for the repetitive transcranial magnetic stimulation, this research has been conducted that provides support of this treatment in patients with bipolar disorder. In fact, this treatment has been found to improve cognitive function in patients with bipolar disorder, so it may just be a matter of time before this use is approved. So both of these procedures will be described, have been described in Chapter 14. I did describe these in the video for Chapter 14, so you'll get this twice. So just be very, it's very important that you read your text. There's just 2 or 3 pages about this in your text, but it's all very important information. And then you have your psychological therapy, cognitive behavioral therapy. We've seen this in almost every one of the chapters that we've been over so far this week. It's usually an adjunct to pharmacotherapy, but the CBT focuses on adherence to the medication regimen, early detection and intervention for manic or depressive episodes. And it stresses and it looks at stress and lifestyle management, which is very important because stress may be a trigger, and the treatment of depression and comorbid conditions. So we do have, in addition to the cognitive behavioral therapy, we also have interpersonal and social rhythm therapy, and this aims to regulate the social routines and stabilize interpersonal relationships to improve depression and prevent relapses. And then we have family focused therapy, and that helps improve communication among family members. So all of these therapies are important, they're useful, and the advanced practice mental health nurse practitioner can carry out these therapies to the patient. So this is your last question, your last practice question. Which convulsant medication might be prescribed for a patient with bipolar disorder? Is it Depakote? Is it Klonopin? Is it Zyprexa, excuse me, or is it lithium or Lithobid? The answer is A, Depakote. One of the options provided, only valproic sodium is an anticonvulsant. So we need to review the classifications of all of these drugs, and make sure you do that. Read your chapter, please. Your chapter 13 is not all that long, got a lot of information in it. But we'll go over this again on Tuesday, and I hope this helps you. I hope this has been um, helpful to you, and I look forward to seeing you on Tuesday. I will not be in class on Monday, but on Tuesday I will be. Thank you so much.